Hello, everyone. Good morning, good evening, good afternoon. This is Prehiwet from the International Institute for Primary Healthcare in Ethiopia. Um, Thank you for being here, and I would like to welcome all of you to this webinar series on strengthening primary healthcare in low and middle income countries. This series was started a couple of months back by the International Institute for Primary Healthcare in Ethiopia in collaboration with the Johns Hopkins Bloomberg School of Public Health. And this webinar series is based on important topics related to primary healthcare, especially topics that are anchored to the recent primary healthcare framework that's the World Health Organization released, and we have had experts from ministries of health, different organizations, experts from CSOs, international organizations join us for this webinar, and we had interesting discussions and a lot of reflections and ideas through this series. Today we'll be discussing about community engagement. So thank you and welcome. And I would like to hand it over to our moderator for today's session, Dr. Micah Schleif from the Johns Hopkins Bloomberg School of Public Health, International Health Department, will be moderating this session. She is an associate scientist at the Johns Hopkins, and she has done a lot of work in the area of community engagement, and I know it's her area of interest as well. And she's also our principal investigator for two of the grants that the Institute is currently working on. So without further ado, let me hand it over to Dr. Micah Schleif. Micah, over to you.
Thank you so much, Frehiwot. It is really a pleasure to moderate this session. I think we have a fantastic panel of speakers who will be bringing some diverse perspectives, a lot of experience, and some insights into what some of the recent advances and current dialogues and some of the ongoing complexities around primary healthcare. So it really is a pleasure to collaborate with the International Institute for Primary Healthcare and so many other partners to make this webinar series possible and to continue bringing forward these really important discussions. The topic of community engagement, or many related terminologies, I think of which we'll probably hear a number of other terms, including community participation, social participation, community empowerment. There are so many terms that mean related things and have meant different things over the years and to different stakeholders. So we may dig into that terminology a little bit today, and I think you'll hear some different terms coming up. But really, this core principle that has been at the core of primary healthcare, at least since the Alma-Ata Declaration, probably before that, that we really need to have a role for communities. We need to work with them. We need to understand where they're coming from. We need to support them. We need to hear their voices, and we need to make sure that they are at the core of the planning, the implementation, the evaluation, the accountability for primary healthcare systems. And so I think that's really what we're aiming to delve a little bit into today. And I think it's really exciting to be able to have now many decades of experience doing this work, and also still, I think, a recognition that there's so much more that we can and need to learn. And be able to sort of integrate into the work going forward in order to continue to work towards the vision of health for all for primary healthcare, of which community engagement is an absolutely fundamental piece. So it is a pleasure to introduce our panel. We will have 4 speakers today. 2 speakers will be providing more sort of the broader framing, have been involved with some important recent global initiatives to move forward in how we think about and support programs and countries, and kind of continue to move the dialogue forward around community engagement. And then we'll have two country perspectives from Liberia and Ethiopia that really bring some of that. What happens when the rubber hits the road? What have been some of the recent experiences, both in terms of more sort of outbreaks and emergencies and crisis situations, but also trying to think through the longer haul and how we really institutionalize and integrate community engagement into health systems governance and planning and program implementation. So I'm going to introduce the speakers as they speak, so that you can connect a little bit the person and the talk. Otherwise, I know that things can get a little bit, it can be a lot of information coming at you as a participant at the same time. So our first speaker is Kira Koch. She's a technical officer at the World Health Organization at the headquarters in Geneva. She works in the Health Systems Governance and Financing Department and focuses on health system strengthening, performance assessments, and participatory governance mechanisms. She's a co-editor of the recently launched World Health Organization Handbook on Social Participation, which she'll be sharing a bit about, and has also been working with a number of stakeholders and providing guidance to policymakers about how to meaningfully engage with populations, communities, and civil society. She holds a Master of Science degree in Health Economics from the University of Bayreuth in Germany, and also speaks English, French, Spanish, and German. So welcome to you, Kira. Thank you for bringing a WHO perspective and a bunch of your experience to this discussion. So over to you.
Thank you very much, Mike, and thank you very much for the nice introduction. I'm very, very honored, and it's a real pleasure for me to be here today. If I can ask now to put up this slide, then I can start my presentation in a second. All right. Okay, wonderful. Okay, so thank you so much again for inviting me, and good morning, good afternoon, and good evening, everyone. It's really, as I just mentioned, a real pleasure to be here with you today in order to discuss this very much important topic. I'm at WHO headquarters here in Geneva, working especially in the space of participatory governance. And that's why I would also like to use the next 10 minutes to focus on participatory governance mechanisms as a means to strengthen PHC. So ways how governments through participatory spaces can meaningfully engage with lay people, communities, and civil society to develop strategies that are more responsive to population needs. So on the slide that you can see on your screen now, I just wanted to remind us about what we are talking about. So PHC is a whole of society approach to health that aims equitably to maximize the level of distribution of health and well-being by focusing on people's needs and preferences as early as possible along the full continuum: health promotion, disease prevention, treatment, rehabilitation, and palliative care, and as close as feasible to people's everyday environment. We therefore have a comprehensive definition of primary health care, which incorporates three interrelated and synergistic components. The first one on primary care and essential public health functions as the core of integrated health services. The second on multi-sectoral policy and action. And the third one, which is our topic and focus of today's webinar, is really on empowering people and communities. Next slide, please. So the question is here really how we can empower people and communities. How can we amplify people's voices and ensure that their needs and demands are considered in health decision-making processes? And the short answer is we need more meaningful government engagement with the population, communities, and civil society. However, as simple as it may seem in theory, it is actually a complex undertaking in practice, one of which policymakers often struggle with. There are many ways how governments can engage with its people, either directly or through the intermediary of civil society groups. A key characteristic of participatory spaces is really the interaction that allow for the back and forth between participants and organizers. So here we are really talking, we are not talking here about the one-way message, for example, for purely communicating information to or solely receiving feedback from a population group, such as surveys, polls, interviews. It's really, and this is of course important, but it should be complementary to this two-way dialogue. On your screen, you see a table which is an exemplary overview of participatory spaces, which is also not meant to be exhaustive. But I'd just like to give you an overview. Firstly, we have the categories of in-person open for all forums who really aim to capture various views from a large cross-section of the population. So for example, open to all forums, open mic, public hearings, etc. The second one are more on consultative methods. So here rather smaller in size, such as consultative meetings, policy dialogues, but also focus groups, which can be extremely useful, especially to hear voices from community groups, from indigenous population, affected population groups who would usually not go to the open for all forums. The third category is around deliberative engagement methods, so rather smaller groups. It's more time consuming and costly, but it allows you to elaborate on a specific topic more in depth, such as citizens juries, citizens panels. And then lastly is the category around formalized mechanisms with 6 fixed seats. And here the district health committees can be extremely interesting, especially from the community engagement perspective, where fixed seats are reserved for community representatives in order to provide their viewpoints in discussions and debates. Really, the key message here is that there is no single best mechanism available. So policymakers are advised to use a mix of various participatory mechanisms to balance out the pros and the cons of each single one in order to reach broad and diverse voices for policy decision-making processes. On the next slide, please. So to render these participatory spaces effective, policymakers really need to think through key issues when setting up, strengthening, and institutionalizing those participatory spaces. And this brings me to the recent guidance document that Mike had already mentioned in the introduction, the WHO Handbook on Social Participation, which I invite you to peruse through if of interest. What we tried to do here was really to pull the available evidence together based on extensive literature reviews and learnings from 9 country case studies that we've particularly done for this handbook to offer practical recommendations to policymakers on the how of social participation. And you can actually see here the chapter outline, and the book follows you really through the different tasks policymakers need to reflect on, such as creating an enabling environment, thinking through issues around representation, capacity needs, ensuring uptake of participatory process for decision-making, which is always a key challenge, how legal frameworks, for example, can support participatory mechanisms, and certainly ways how to sustain participatory engagement over time. In the interest of time, I will not go into all of the chapters, but I like to focus on 3 key chapter findings. In chapter 2, on the next slide, we really lay down the fundamental premise of the handbook, and that's power dynamics. Power dynamics are ingrained in any country's political, social, and economic landscapes, and they create unequal conditions for participation because they pose structural barriers to participation for some parts of the population, usually those who have less of a voice, and inadvertently increase access to decision-making structures for others who already hold power and influence. So meaningful participation is brought about by evening out that playing field within the participatory space as far as possible. And what we mean by that is counterbalancing the inherent and ingrained power imbalances that exists in every society for purposes of that participatory space. And we elaborate on the notion of a participatory space where participants who are generally weaker and less powerful, such as community members, vulnerable population groups, are empowered to the maximum extent possible to express their views and experiences without fear of reprisal or undue consequences. And this actually signifies, and that's the difficult part, a humbling of voices who are usually more influential, such as policymakers and government cadres. But ultimately, and this is really what we try to demonstrate in this book, it is beneficial to all participants, especially to those who are using holding power and influence, as an enabling environment can act as a great catalyzer for the participatory exercise. The participatory space can thus be a very potent tool to minimize the power asymmetries if, and that's a big if, designed in a way that counters formal and informal barriers for equal participation. And there are ways how to lend those with less voice and agency countervailing powers through the format and design of the participatory space, and through that thorough reflection of the participatory process. And as we can see now on the next slide, on especially talking and starting with the thorny issue of representation, which is really one of the most oft-cited concerns of stakeholders and social participation and community engagement efforts, because representation is so closely linked to the issue of legitimacy and credibility. The widely held notion being that if those who are part of a participatory process are representative of whom they are supposed to represent, for example, the community, then they are also considered legitimate. And more importantly, the results of the participatory process are then also seen as legitimate. However, legitimacy and representativeness is something that is not an inherent quality of a person per se. It is also something that is conferred through a well-designed and thought-through participatory process. And here, it's really about being transparent and explicit. Being explicit about the selection strategy and also about the roles of the representatives. So for example, why is it important for the policy question at hand to listen to the experience of a community representative? And it's important that this is clear to everyone around the table, especially to those who used to hold power and influence, why it is that this person is here and why we want to hear, for example, from his or her lived experiences. So by being transparent and explicit about representatives' roles, we can lend them with more legitimacy and credibility. And you can see a couple of examples on your screen how this can be done through format and design, such as neutral facilitators, homogeneous focus group, preparatory material, meeting location, especially here looking and asking to go into the rural communities, for example, instead of requesting them to come to larger cities and capitals. One of the principles which I really would like to highlight is really that special attention on who is not participating and subsequently reaching out to those often marginalized community groups, because otherwise representation can lead to further inequities. And on my last slide, please, I'd like to come to the issue, of course, around capacities. And again, it's about recalibrating the balance of power, which is rooted not only, but largely in expertise, knowledge, and speaking skills. We know that the quality of exchanges is largely determined by the competences of the participants, but also by the capacities of governments and organizers of these participatory spaces to enable that level playing field, where participants are on an equal footing as far as possible, which allows for that more frank and fruitful discussion, which can then lead to the real policy influence. We have put in the chapter 3 key capacities for social participation. The first one really on recognition, so which is actually the most fundamental, because it's the most difficult to build, the recognizing the added value of participation and community engagement initiatives. The second one on communication, in particular also here for civil servants, the capacity to listen and also to provide feedback post-consultations. as well as the ability to translate some of the complex health systems, issues, and primary healthcare concepts into relatable and concrete real-life issues in simple and non-technical language. And lastly, technical skills on the policy question at hand. But again, those technical skills can be compensated for by providing materials or having experts on call. Again, it's a lot about the format and design issues that matter when policymakers organize such participatory spaces. And just maybe as a final word, I really like to put forward those 4 key messages. The first one is effective social participation and community engagement can foster meaningful dialogue and trust between the population, community groups and the government, while strengthening accountability measures. The second one, meaningful participation really means empowering people who usually have less voice and influence to express themselves clearly. Thirdly, policymakers should make that conscious effort to level out power imbalances between participants by organizing a participatory process in a way that everybody can meaningfully contribute. And lastly, and for this, we need heavy investments in creating, strengthening, and institutionalize those participatory mechanisms in order to foster a culture of participation that uses ongoing dialogue between people, communities, decision makers to arrive at that more responsive and sustainable policy solution. And this really goes beyond this ad hoc engagement to the creation of institutionalized structures and processes over the long time with sustained funding and capacities. So I will stop here, and I very much thank you for the invitation, and I look forward to our discussion afterwards. Over to you again.
Thank you so much, Kira. I think that was a fantastic presentation, and I think it brought up some really fundamental sort of themes and points that I imagine will be coming up again in some of the following presentations. So thank you for pinpointing both some of the challenges and the real importance around some of these approaches, including power dynamics, the representatives that we are engaging with, and then the capacities of both communities and some of the other stakeholders that engage with them. So excited to talk more when we get to the discussion. I would like to now turn to our second speaker. I'm very excited to hear from you, Rania. So Rania Alessawi is a social behavior change specialist with Unicef in the headquarters in New York. And previously to her work at the headquarters, she has worked extensively at country level across a number of different regions of the world. So she may bring in some of those experiences and examples as well. In her current role, she supports development and provision of technical guidance for enhancing social and behavior change quality programming in both development and emergency and humanitarian contexts. She also works on management and dissemination to UNICEF country and regional offices, as well as to external audiences, including development partners and sharing results and evidence and good practices in the CD4 programming. She specializes in mobilizing and establishing platforms for engagement and advocacy with national partners, including governments, non-governmental organizations, as well as donors. And her work has included facilitating social policy dialogues, establishing strategic partnerships, institutional strengthening, developing capacity building programs for government and non-governmental partners, and implementing participatory planning mechanisms. Her emergency and humanitarian experience has been in coordinating and strengthening the Ebola response during the West Africa Ebola crisis, and also cholera response in conflict-afflicted areas, as well as accountability to affected populations. So welcome to you, Rania, and looking forward to your presentation as well. Over to you.
Thank you so much, Mike, and thank you so much for that introduction. And I'm really happy to be here and speak about community engagement and what the approach that UNICEF has been taking over the last few years. But just before I start off, I just want to say that everything that we do as UNICEF, we do with partners. We do it with our government as well as our civil society partners. And just to give context, we have 7 regional offices that cover about 129 country offices working in 150 countries in the world. So everything that we present and represent has been built through consultative processes and represents joint efforts. So next slide. Maybe I'll pick up and just also mention and just link with what Kira just took us through, and picking up from where she was saying about the need for investments to foster, I would say, transformation at society level, not just at community level, because communities could be defined very differently, and that's what we're going to talk about in what I will be presenting. But the most important thing is that people or communities have different roles across society. And within that, what we aim to achieve through community engagement is transformation at a societal level. So when we talk about investments also, that spans over many different roles that a person or an individual will be playing within the different communities that they engage in. So they could be engaging at their family level, they could be engaging within their role within government or within private sector, etc. So just in framing that, building trust is a long-term and dynamic process. It's a relationship. So understanding the dimensions of power, influence, authority, and what we aim to achieve through community engagement need to be focused on community engagement outcomes. And I'll talk more about what we mean by community engagement outcomes. But what I do want to just, I like to start off with is just the reminder of, why we do what we do and why we're all here. Because somehow in all our intersections, we're all working towards achieving the 2030 agenda. And within the 2030 agenda, one of the most strategic things that was mentioned was the focus on achieving whatever progress we do within the development context and growth, economic, social growth within our countries, that it is focused of the people, by the people, and for the people. Meaning they are not passive bystanders, they are not beneficiaries, they are stakeholders. And ensuring that we bridge the gap between people within their social, cultural, economic contexts and what we require to put in place at national policy level to ensure that meaningful participation and engagement actually happens, that these processes are actually intentional and systematic. So this is just a quote actually from one of the General Assembly meetings back in 2017 when the 2030 agenda was adopted. Next slide. So I'm going to talk about the community engagement minimum standards. If you can just click through, sorry, sometimes I have animation when I'm doing it myself. So what I would like to speak about are the community engagement minimum standards. These community engagement minimum standards, if you have not heard about them, hopefully you will be able to engage with them. But these standards were developed over I would say it was originally planned for a year process, and it extended to a 2-year process that was quite consultative, in which it started in 2018. We worked with policymakers, practitioners, academicians across the multiple regions that we do work with. So we engage with many of our country offices that then engage with civil society partners as well as our government partners. In this process, what we aim to do was to establish a common language among the different stakeholders for defining community engagement principles, key actions, goals, and benchmarks. All that to rethink, when we say community engagement, what do we actually mean by that? But that the end goal is that what we want to achieve is high quality and evidence-based community engagement. So based on that, these are the global principles that were agreed upon through the work that through the work of everybody that was involved, basically. The standards are intended to be used as a tool for development as well as humanitarian actors and the governments that we work with. It seeks to ensure meaningful integration of community engagement standards in all aspects of community engagement practice. So thinking from government programs as well as the different methodologies, participatory approaches, how do we integrate, how do we coordinate, and how do we drive investments and resources into community engagement. So in order to achieve an enabling environment, these specific global principles are interconnected, and they were key challenges as well as opportunities that we wanted to make sure that the community engagement standards addressed. So starting with quality, what we hope is that achieving quality at scale requires us to have common languages. It requires us to establish criteria as well as benchmarks, as well as actions. In terms of harmonizing our efforts, it's more community engagement is not necessarily better. The aim is that we optimize what we do in our interventions. So the concerns of the effectiveness of what we do within development as well as humanitarian practice calls for better accountability as well between the implementing agencies, between donors and financial institutions, and how they drive investments to communities, or not to communities, but how do we raise that kind of accountability? So with these 4 principles in mind, we hope to fulfill responsibility as stakeholders within these community engagement processes in the design, implementation, and evaluation of community engagement. Next slide. And just by the way, in this presentation that you will receive, there are hyperlinks to most of the documents that I mentioned that I'll be speaking about today and referencing. This is just to say, to give a quick overview, and just to say that in everything that we were doing in the design of the community engagement minimum standards, we wanted to build on what is existing. There has been historic engagement through UN and civil society as well as governments. There are global and international norms and standards that all countries and institutions actually abide by. These are just a few of them. But the ethical foundations that the community engagement standards aimed to draw on are what I highlight here. And within the document, it gives references to how we build on implementing a human rights approach, maintaining quality and accountability, do no harm, and thinking about gender mainstreaming from a responsive perspective. So when you do get to go through the document, you will be able to access all of these also resources. Over to the next slide. So one of the things that we did do is we aim to establish the definition. And as I mentioned, this consultation went through 2 years of many back and forths about just identifying and having a consensus around how do we actually define the process of community engagement. And I'll speak to when we worked on developing the standards and then the actual indicators, all the roads lead to being able to achieve what we defined here in the definition. So what we specifically focus on is saying that community engagement is a foundational action for working with traditional community, civil society, government, and opinion groups and leaders, and expanding collective or group roles in addressing the issues that affect their lives. And within every single one of those traditional community, civil society, government, we actually mention who that actually incorporates. Because as we know, community engagement is quite a complex process. And sometimes we aim to oversimplify, but it is a complex process. So in simplifying, we need to identify the complexity within it and recognize that, so that we have the accountability to also optimize what we're trying to do to achieve community engagement. So next slide. So now I'll just give a quick overview of what is actually included within the community engagement minimum standards. And I hope that this excites everybody as much as I am excited working on this. Ever since we launched it in 2019, 2020, it was right as COVID was coming in, and how that's changed our lives. Community engagement and social behavior change was really at the core of everything that we were doing. Always within crisis in particular, behaviors and community engagement is the most critical element. Before vaccine comes in, community engagement is the most critical element as donors, but oftentimes it is one of the most challenging areas for us to drive systematic investments in. So the framework that we developed or that we landed on, I want to say, because I just really want to stress the participatory process that went into this. we agreed on having 4 core components within the community engagement minimum standards. The first one focuses on what are the core standards, and I'll explain that in the next slide. But what we identify are 6 core standards to say, these are the bare minimum standards and actions that need to be taken when we are developing and designing community engagement interventions. Parts B, C, and D focus around the operationalization, which includes implementation, coordination, and resource mobilization. And then what we also incorporated after extensive review of thousands of indicators, actually, from program documents, government systems, etc., we landed on a proposal around adaptable indicators that could be proposed and taken up by national and local governments, NGOs, civil society, and implementing agencies for all stages of community engagement programming, from conceptualization to evaluating. And then what we also incorporated is checklists within that, so that partners can actually use that. So one is a project cycle checklist, and one is funding institutions. Could be used by funding institutions when they're looking at programs. This is how the community engagement standards, these are the core, the community engagement minimum standards. There are 16. The 6 core ones, and then the 10 operational indicators. I'm not going to talk through them in full detail, because I think what's important here is for you to be able to actually access the document and engage with it, and also look for opportunities to partner with many institutions that have been working on implementing these standards. But these are how the community engagement standards have materialized. They are being applied in different contexts. So what I want to actually give an example is the application within the PHC space. Next slide. And we can skip the slide. I think all the partners here actually have a shared understanding on the community engagement platforms and partners. So I'm sorry that the text here is super, super small, but when you do receive the presentation, you'll also have the links to this. So what I want to really highlight is the work that we've been doing with the WHO as well as partners across the globe. And as you all know, the PHC framework has been evolving within the last, I would say, also 2 years and adopted. And there's been many resources and tools to focus on within the new PHC framework and the 3 pillars that define PHC. Where does community engagement come in from a systems approach? And what is such a great opportunity is that the new PHC framework, and this is the M&E framework actually of the PHC framework, it integrates community engagement and social behavior change across many pillars, from the systems to the processes to the actual outputs and outcomes. Because if we want to achieve community engagement outcomes, around empowerment of communities, around inclusion, we need systematic processes. And what we also don't measure or budget for, then it doesn't happen. So if you could just click on the slide, just one more click. Yeah, so these are the areas where I highlight where there have been identified, and these are definitely opportunities for us now at country level, because in every country, there are the multiple partners that work on PHC with WHO, with Unicef, with the government. And these are the opportunities and the entry points for us to look at how do we systematically support our government and our civil society partners to better develop community engagement actions. The community engagement minimum standards support by providing quality criteria, definitions, and actions. This is the PHC framework, which defines the entry points that we can actually work with our government and civil society partners on how do we actually bring that to light and how do we actually implement it. Next slide. So yes, so I just wanted to give just a quick overview and share this back and as a refresher for us, because within the PHC theory of change, as you can see, these are the 3 pillars. The first one looks at the health system itself, and then there is the pillar around empowered people, and then multi-sectoral policy. And as we all know, community engagement, because it is such a complex process, even working within public health and to achieve public health outcomes, we often have to do that across other sectors. So we need to engage with the water and sanitation sectors. We need to engage with the nutrition sectors. We need to engage with child protection sectors or social welfare sectors, as well as local governance. So what I really like about the PHC framework is that it recognizes that community engagement actually comes across all the pillars of the PHC approach, and it is a call to action for multi-sectoral approaches. Next slide. Yeah, sorry, this was just as an example. I'm sorry, this was just as one last example about, one example of the opportunity for entry. How do we strengthen, therefore, health information systems? This is an opportunity within the PHC framework that actually looks at how we generate data for PHC monitoring. And, as a community and as partners that work on PHC, over 80% of the indicators from PHC are around these specific areas. And as you can see, qualitative assessments or facility surveys or individual patient records or community assessments, those are all opportunities where we can be integrating community engagement processes. So this is just a quick idea just to say, here are possible entry points. Next slide. So my last two slides are talking about challenges and then opportunities. So I'm going to skip the challenges because I think we all can agree on what challenges exist, but I'll speak about the opportunities, and then I can wrap up because I know that we're pressed for time. Next slide, please, Biru. Okay, so I think what I would like us to come out of this is, yes, all these wonderful global frameworks are just as good as when they're operationalized. We have opportunities to operationalize. With all the efforts that have been happening globally, this always builds on what's already happening in country offices. So everything represented here is building on what's already being translated and what governments are already taking up as commitments. I think one of the things that we need to continue to do is ensuring that when we are thinking about community engagement, we are taking it from a system strengthening approach. Community platforms, community leaders, representation, networks, the real people that are actually doing the work are there and have been there and will continue to be there. Being systematic about driving investments and establishing these partnerships with these platforms is critical. And I think as partners within civil society and within government, ensuring that what we do is systematic. We provide financial resources, we invest in local capacity building, we invest in human resources. All of that requires many assets, many capacities, but there is a consensus that this needs to happen. So as we approach health systems through a system strengthening approach, we need to do the same around community systems. We need to work not just at centralized mechanisms, really community engagement and the bottom up, we need to engage with decentralized mechanisms and platforms. And I think I will stop there and leave the rest up for discussions. There's many examples that we would, of course, love to talk about within countries, but also more so what I would love to leverage is the opportunities for partnerships, because for this to happen at country level, it needs to happen through the dialogues that are already happening. Thank you so much, everybody. And these are just a few questions that I like to leave everybody with. My email is included in the presentation and looking forward to the questions. Thank you.
Thank you so much, Rania. This is great. And I really appreciate your focus on sort of the partnerships and how much collaboration already has gone into this work. And then also really the recognition of, where this work actually is happening, who's actually doing it, and, how that's all linking together. So I see there's a lot of interest in learning more and the content that's been shared so far, which is fantastic. We will be sharing PDFs of the slides with everyone after the session, so you will be able to dig into this more. And now I think your segue, Rania, into that sort of, where is this work happening and how is this sort of leveraging the country work is a great one for our second set of speakers. So next, I would like to turn over to Dr. Dugbe Christopher Nyan from Liberia. He's a medical doctor and a biomedical research scientist and inventor and a social activist. He earned his medical degree in human medicine from the Medizinische Fakultät Charité der Humboldt-Universität zu Berlin in Germany. He was trained and also worked as a scientist in the US National Institutes of Health and the University of Pennsylvania School of Medicine. In 2014, Dr. Nyan testified before the US Congress on the Ebola epidemic in West Africa and served as a member of the Data Safety Monitoring Board of the Prevail Ebola vaccine trials as well. Dr. Nyan has published in reputable scientific journals and is the winner of the 2017 African Innovation Special Prize for Social Impact for his inventions. He's a member of the International Society for Infectious Diseases and the European Society of Clinical Microbiology and Infectious Diseases. And Dr. Nyan currently serves as the Chief Medical and Scientific Officer for Shufflex Biomed, a diagnostic startup company that develops rapid testing kits for infectious diseases. So Dr. Nyan has really been at the forefront both of innovation as well as public health practice in Liberia and beyond. So we're so happy to have you. Dr. Nyan, over to you.
Thank you very much for this wonderful introduction. And we have the slides, please. I will be speaking to you regarding the experience of our public health engagement in Liberia during over the course of time and during the Ebola crisis, all through the current pandemic. Well, for those of you who may not be familiar with Liberia, it's on the West Coast, founded in 1822 and declared its independence in July of 1847. Its current population is about 5 million. Life expectancy is about 66 for female, 63 for male. And we have an infant mortality rate of 63 per 1,000 lives. Next slide, please. The Liberian medical setup and public health delivery care is such that we have government hospitals in the various counties. There are 15 counties, which are the political subdivision of Liberia. We have government clinics in the districts, and then we have major referral hospitals, notable among which is the John F. Kennedy Hospital, named after former President John F. Kennedy, the late John F. Kennedy. We have the St. Joseph Catholic Hospital, which is a private hospital. We have the Jackson F. Doe Memorial Hospital, which is located in a county called Nimba County, where the Africa Union today, which was then the OAU, was born several years ago. So happy African Liberation Day to all of you who are watching here from all over the continent. We have Phoebe and various other hospitals that are private-based or are supported by religious institutions. We have then community clinics, some of which are some makeshift clinics, but these clinics exist in various communities. And you have them in both private and public health care. Next slide, please. So all of us know in the low to middle income countries, particularly in our African setting, there is an array of infectious diseases and other diseases with which we are confronted. In Liberia specifically, this particular slide shows the investigation done between 2009 to 2019, a 10-year study, looking at malaria and various other diseases. You see that malaria is the major killer, is the major cause of death in Liberia, just as many other countries in West Africa and around the world. Then diarrhea diseases come next, and we have the neonatal disorders ranging to HIV and AIDS, and all the way to maternal disorder, which include postpartum hemorrhages. And these are very, very troublesome within the region, and particularly within Liberia, given the healthcare situation and the disposition with which we have faced since the Ebola crisis. Next slide, please. You will note that the Liberian medical and healthcare delivery system is in a very dilapidated form, is challenged, and that is occasioned by the 14-year civil war and then the Ebola crisis. Those who work during the Ebola crisis in West Africa, particularly Liberia, Guinea, Sierra Leone, would have come in contact with how dilapidated the healthcare system is, how challenged it is. It has limited diagnostic capabilities and limitation in disease surveillance. There is a much dependence on donor countries for assistance in helping the healthcare delivery system. Is challenged with the question of skilled technicians and skilled medical professionals because of the brain drain, which has caused a lot of exflux of highly trained medical doctors, nurses out of the country during the Civil War and during the course of these times. One of the challenges faced is poor resource allocation to health, and we will come to that later. Also, if resources are allocated, the maintenance of healthcare of the healthcare system has been challenged because of the poor maintenance system. Primary among which is the lack of political will and systemic corruption, which has hindered the growth and the management of delivery of healthcare system in Liberia. You will note that, for example, there's a budgetary misallocation as one of the challenges we talk about, as it relates to how policymakers relate to healthcare and other sectors. The national legislature on the very top during the fiscal year 2022 allocation received almost $64.3 million. And the Ministry of Health, which is just a small government entity that is located within the executive mansion, received $20.3 million. But when you come down, looking at the hospitals that I just told you about in my previous slides, the John F. Kennedy Medical Hospital, which is the major referral hospital in the country, this hospital was the major referral hospital in pretty much Africa south of the Sahara back in the days. It trained a lot of doctors, a lot of nurses, and a lot of other healthcare professionals during the 60s and the 70s. This hospital is allocated only $6 million. The National Public Health Institute, which is like the Center for Disease Control in Liberia, is allocated $2.6 million. And the Jackson F. Doe Memorial Hospital, which is a major referral hospital, also going east and down the south, is allocated only 2.4. So you can see the disparity, which presents a challenge to public health and healthcare delivery. Next slide, please. Now, the disease spectrum have changed and have switched. As I had informed you of those infectious diseases, which I indicated on the previous slide, we also have a shift in the disease spectrum. So we're not only dealing with infectious diseases like the malaria, yellow fever, Lassa, etc., but we're also confronted with diabetes, and it has gone up in the last several years, as well as hypertension and cancer has been reported in various hospitals. Next slide, please. In this case, it predisposes certain solutions that we want to present here. It requires then intense community engagement due to the lack of enough financial resources in order to carry out effective public health engagement in terms of community engagement at the local levels. It requires development of radical, innovative healthcare policies in order to get away from donor dependency, for example, because most of our countries, particularly Liberia, is much more donor dependent, and without that, the healthcare system will completely collapse. We're proposing locally operating multinational companies to infuse their profits back into the community healthcare. Community healthcare is very important because the same workers of these multinational companies come from the communities. And it's been noticed, in fact, that one of the companies had just recently contaminated a waterway, a drinking waterway of one of those communities. And that is now creating health problems because the fish and other things are dying, other living creatures within that pond, and the water is dying. We need highly skilled family doctors, particularly so who are to increase the clinical capacity and for increased resource development. there needs to be an increase in budgetary allocation for healthcare. As you noted on the previous slide, the disparity between what executives and legislature take for take-home pay, for example. Legislature take home about $15,000 a month, while a full-grown medical doctor takes home pretty much $2,000 or less a month. This kind of disparity is very discouraging to promoting public health and primary health care and healthcare delivery in our communities. During the course of this time, we have tended to engage with the community specifically. As you will see on the pictures on the left, given all of these challenges, we engage the communities directly and inform them of diseases, particularly during the time of this COVID-19 pandemic, informing them and educating them on the danger of the virus, its transmission process, and the very measures that have been put in place: mask wearing, hand washing, and just the minimum primary and preventive healthcare measures that have been exercised. In the bottom picture, you see another community engagement, which was organized by one of the senators, Senator Komne Wise, at his house. And so I went there as well and engaged that community. So what we did was to engage these communities through their leaders that come from those various zones. And those leaders then take back the messages to their communities. This ensures confidence, and it ensures a penetration of the larger community members and dwellers. Next slide, please. This again is another slide where we were talking about immunization, as you will see, specifically relating to the COVID-19 vaccination, where we talk about citizens' engagement and national responsibility. So we gathered some university students and students in the public health area, as well as public health practitioners from the National Public Health Institute, and provided them lectures on the vaccination, the vaccine, particularly the COVID-19 vaccine, the manner in which it would be administered, and the side effects and everything that goes along with the COVID-19 vaccination. This was done because of the huge community hesitancy. And so it was very important to engage the community at the student level, because the students come from in the communities, and then engage the community leaders because they are kind of head of the communities, and through that the message will penetrate the communities in which they live. This got us to increase vaccination rate. Entire communities and radio stations, for example, helped in this process. We went on radios and utilized that as an effective communication tool in order to communicate with the population. So entire radio station took their vaccination, which, you know, of course, is one of the major means of disease prevention in public health and community health advocacy. So I would like to stop this far and leave the rest for discussion due to time limitation. Thank you very much.
Thank you so much, Dr. Nyan. That was an exciting perspective, bringing in some of the sort of innovative strategies and then thinking through, you know, in each particular context, what kind of engagement can you get through different channels, through political leadership, through different communications channels, and then, you know, really bringing communities together through their leaders and, you know, by really reaching them and listening to them during challenging times as well. So thank you so much for that. Looking forward to more in the discussion. And now I'd like to turn to Desalu from Ethiopia to be our final presenter, and hopefully bring back to Ethiopia, which obviously is the base where the International Institute for Primary Healthcare is based, and to bring in some of the experience from the Health Extension Program. So Desalu is a project director at JSI's L10K for a CIF-funded Health Extension Program Performance Improvement Project. and for a new Gates Award around improving primary healthcare service delivery project in Ethiopia. He has nearly 20 years of experience in program management and technical leadership in community and primary healthcare systems and community engagement, as well as digital health programs. Before taking the project leadership role that he has now, he served as a project director at the Marie Stopes International Ethiopia office for a DFID-funded family planning project, and has also served as a PHC team lead and RMNCH technical advisor and regional manager previously for JSI and L10K. During his earlier career, he also worked as a reproductive health program officer at Engender Health Ethiopia and took different positions in the government health system, starting from healthcare facilities as the primary healthcare director and the health science college lecturer and reproductive health program officer in Amhara. He holds a Bachelor of Science from the Alamaya University and an MPH from Addis Ababa University, and will be sharing some experiences from Ethiopia's health system. So over to you, Desalu, and thank you so much for joining us.
Thank you, Mike, for the generous introduction. And hello, everyone. Good morning, good afternoon. Thanks for your interest in joining our webinar. So I will be speaking on Ethiopian experience in community engagement in primary healthcare system, how community engagement is embedded and linked with the Ethiopian primary health system from Ethiopia. So I'll be speaking the country experience and GSI support in this space. So I'll be focusing on community linkage with the health extension program and evolution of the Ethiopian community engagement strategies over time and contribution of those strategies in improving health outcomes and the current optimization strategies of the community engagement approach. Next slide, please. So in Ethiopian primary care system, the community is well embedded in the health extension program and primary care. Here in Ethiopia, we have three-tiered care system, which includes the tertiary care, the secondary care, and primary care. So the primary care system is a foundation of the health system, which includes the primary hospital, health center, and health post. So the health posts are where the Ethiopian health extension program is being implemented, where in the health post, 2 women health extension workers are staffed, implementing about 18 core packages, including preventive, curative, and promotive health services. And they are working with the communities, especially currently with women development armies and families. So under each health post at village level, there are women development army groups, usually 20 to 30 women development groups on average at each village level. And each women development group constitutes about, again, 25 to 30 households, where each group has its own leader, usually interact with health extension workers to have information exchange and review performances. And the women development group members usually meet at village level to share their experiences and share lessons and discuss their challenges. Usually the HEWs and the women development leaders usually promote key messages related to the health extension program. Next slide, please. Next slide. So for the last 20 years, the Ethiopian community engagement approach evolved over time, which started during the launch of the Ethiopian extension program, which was launched in 2003. And the program expanded to across the country, initially to the pastoral areas in 2007 and to the urban areas in 2009. And currently it is being implemented across the country. And now the government launched the HEP optimization and developed a roadmap to guide the evolution of the Ethiopian extension program for the next 15 years. So, which is embedded, the community engagement over time. Previous slide, please. So initially it started with model family training when we launched the extension program. Then the model family training includes training of the households for about 90 hours on key health package. And the HEWs usually mentor the households and graduate as a model family. But because of the coverage issues and qualities related issue with model family training approach, the community engagement strategy evolved into Women Development Army strategy, which was launched in 2011. And currently we are implementing that, but because of the HEP optimization approach, the community engagement strategy is also optimized. We'll be talking this in detail later on. Thank you. Next slide, please. So to talk about on the Women Development Army approach, just to address some of the challenges of the model family approach through establishing a Women Development Army, which is an organized woman-led movement. Usually every woman in the household network with their neighbors into an organized women group. We call it the Women Development Army group. So this groups have some discussions at village level, which is a kind of a participatory and action process to discuss their barriers and challenges in accessing care. And they usually share experiences and design some solutions sometimes and link with the health system on how to address essential care. So in order to improve the interactions between families and communities with the health extension program, different approaches and tools have been designed. In GSI, we set up some tools, including a family conversation, where discussions happens at pregnant mother's home, whereby to create enabling environment for pregnant women so that she could have care, antenatal care, and skilled care at the facility. So at the family level, the husbands and household decision makers usually engaged. And there are also some strategies related to the community dialogues, where at village level discussions happens related to health, including HIV/AIDS. There are also some tools, including we call it the community-based data for decision making for the Women Development Army leaders, which is a kind of a surveillance system to identify the health needs of households by Women Development Army leaders, so that they identify the health needs of their catchment households and link with the health extension program for care. And there are also some tools, including birth notification, communication tools. We call it the family health guide, home visit cue cards and checklists, and so on. We'll not do the details, but there are a lot of interventions and tools to improve interactions between families, communities with the health system. Next slide, please. We measured each interventions whether they improve interactions with HEWs. So we did a kind of implementation fidelity study, and we found out that HDA, or the Women Development Army implementation fidelity, is strongly associated with health outcomes, specifically for RMSH outcomes, and including household latrine use and household visit by HEWs, possession of some of the communication materials, and use of essential services. So when the HEWs and Women Development Army have a strong interaction, usually it improves health outcomes. So next slide, please. So based on the evidence we have from some selected areas, we package some of the interventions, effective interventions, to package, and implement at scale. And we found out that when we implemented in 115 districts in agrarian settings, so we found out that for the last, for 10 years, there was a significant improvement in utilization of essential services, especially RMSH services, as you see from the graph. Family planning, antenatal, institutional delivery, and immunization services improved significantly because of the approach, the community approach that the government has implemented for the last 15 years. This is in project side, but we'll see how this strategy impacted the national health outcomes. Next slide, please. So when you see the national health outcomes or gains in health outcomes for the last 20 years, Actually, this might not be directly associated with the community engagement strategies, but it is overall the expansion of the primary care and the community engagement strategies. There was significant improvement in maternal health services, including family planning, antenatal, and skill delivery care, which especially the skill delivery care, which was about less than 5% some 15 years ago. Now it improved to nearly 50%. So this is the community engagement strategies, the national movement and expansion of primary care in general contributed in significant improvement in maternal health outcomes in Ethiopia. Next slide, please. Well, this is the child effects on child health. So Ethiopia is still, has been and is still one of the country with major high mortality rates, child mortality rates, but in terms of progress for the last 20 years, because of the launch of the health extension program and the community engagement strategies, which is the Women Development Army approach, there was significant gains in terms of reducing under-5 mortality and child mortality rates. But for the last 10 years, there is a stagnation of improving the neonatal mortality. But in terms of major cuts in the mortality rates, the expansion of primary care and community engagement strategies contributed in improving child health outcomes in Ethiopia. So after implementing for about 10 years, the Ethiopian government launched a national assessment of the health extension program. So the evidence shows that, I mean, the existing Women Development Army strategy has contributed a lot in terms of improving access to and utilization of services, but it has its own challenges again. So the government managed to mobilize over 3 million Women Development Army leaders across the country, which is owned and led by the government. And this strategy contributed in improving women's agency toward this, decision-making and accessing essential healthcare services across the country, and which accelerated the health extension program implementation. So this strategy usually works best when there is a strong engagement of the administration, I mean the local administration, and where it is well linked with the primary care system. But it has its own challenges, which includes increased workload of the HEWs, demotivated health extension workers, and limited skills of competencies of the Women Development Army leaders. And there is a wide perception that the Women Development Army is politically affiliated, and it is criticized that this strategy systematically disengages men and youth, as all HEWs and Women Development Army leaders are women, so it systematically disengages men and youth. So based on the findings, the government launched an optimization strategy, optimizing community engagement strategy, and the ministry went through an iterative and multi-pronged approach, starting from evidence generation and policy dialogue, and employing a human-centered design approach to, understand the needs and the voice of communities, and bringing the needs and the voice of communities into the policy table, and shaping the national community engagement strategies, and with iterative consultations and discussions with stakeholders and political leadership, with a series of iterations. So the government, redefined the existing community engagement strategies, which includes, the next slide, please. So the government launched a new redesigned community engagement interventions. We call it optimized community engagement strategy, which includes adding or introducing the village health leaders intervention to bridge between communities and the health extension workers. These village health leaders are more literate and gender mixed, so that it would address the gender dynamics, engaging both men and women and the youth, and actually optimizing the existing Women Development Army strategy is very important. And again, men engagement, engaging youth and school communities in health sector was identified as one of the interventions to be implemented at scale, and engaging informal social structures, including religious and cultural institutions in health, and designing sustainable motivation mechanisms for community volunteers was identified as strategic interventions to optimize the Ethiopian community health, community engagement strategies. So these strategies are under pilot testing and test of scale phase. So the government is packaging effective interventions to go to scale. So these are some of the interventions that the government has designed and started testing in agrarian settings. And the ministry is also exploring options to design tailored community engagement strategies for the pastoral communities. Next slide, please. Next slide. So this is my last slide. So in conclusion, the Women Development Army approach accelerated the HEP implementation and helped the country to achieve most of the Millennium Development Goals. And the government ownership and support at all levels was key for the success, and evidence-based tools and approach to improve interaction between communities and the primary care system was essential. And of course, agile and adaptable strategies to meet the program and the community need is also essential to have an agile and dynamic community health system. Thank you.
Thank you so much, Desalu. This is an immense amount of work that you've represented here, and it's exciting to see the efforts to really dig into what where some of the challenges and opportunities are, and then see the progress towards a further strategy. So thank you so much to all of the speakers. We have about 12 or 13 minutes for some discussion here, and then we'd love to hear from other participants after the session as well, if you want to reach out to us. Also, if we don't get to answer all of the questions during the session today, which we probably will not, we will be happy to follow up on them after the session. So the plan is to start with a couple of questions focused on the country examples that we've heard from Liberia and Ethiopia, and then come back to the whole panel for a couple of broader questions and some wrap up. So the first question I would like to direct to you, Dr. Nyan. There was a question around if you could say a little bit more about in Liberia how communities have sort of been strategically engaged around Ebola, or more recently with COVID-19 as well. So would you like to comment further on that?
Yes. Much of the engagement in the communities have been done primarily by non-governmental organizations. I know the government has made some efforts, but much of that has been made by non-governmental organizations and individual scientists and medical professionals who've gone into the country. During the Ebola crisis, there was an organization around the communities because of the infections going through the communities, spreading through the communities. So communities were organized to become sort of a watchdog for infectious persons, and to report to the health authorities. And so basically, those are the manner in which the communities have been engaged. The community themselves have their own local organizations. And once those are spotted, they are brought into the mainstream of the public health mobilization and primary health care mobilization, so as to continue to perpetuate that which is required to uphold the health system in the country.
Thank you so much, Dr. Nyan. I want to pass back to you, Desalu. I think there has been some great discussion about the Ethiopian primary healthcare system, and specifically community engagement, and a bunch of different facets of that in both the Q&A and the discussion. I think two themes that are coming out there are around sort of the functionality and other further ways to continue to support the Women Development Army structure, and how that's being supported in the Ethiopian context. and also the pastoralist communities and what can be done further to support community engagement in those contexts. So if you want to speak to either or both of those and any other sort of themes that you've seen related to Ethiopia from the questions so far.
Thank you. So these are great questions. So in terms of supporting the Women Development Army strategy in Ethiopia, so this Women Development Army strategy is a government-led initiative. So the government at all levels are focused and on this strategy. So every level from the government, starting from the community level, the local government usually leads this initiative. Currently, this initiative is led by the Women Affairs Ministry, but the HEWs are part of the local administration. So usually in the health sector, the HEWs directly support and train the Women Development Army structures to optimally use, this platform, this structure to, engage with the communities and access households and individuals, so that the HEWs implement the health extension package using this platform. So HEWs directly train the Women Development Army leaders. They supervise, mentor, and have exchange of information and review performances at local level. So the ministry at national level develop guidelines and curriculums to capacitate the Women Development Army leaders. But in terms of structuring, the Women's Affairs Ministry is leading that initiative. So the role of health sector is using that platform to advance health outcomes at community level. In terms of contextualization, this Women Development Army strategy usually works better in agrarian setting, agrarian rural settings, but there are also trials in urban and pastoral contexts, but needs much contextualization. There are different structures as pastoral settings, including the social mobilization and using the clan structures, the local structures. So usually they have their own social mobilization structure. So the government is intending to optimize that platform using, an iterative approach, and the government is intending to have a kind of anthropological study to understand the context in pastoral communities and design strategies accordingly. Thank you.
Thank you, Desalu. So I want to open to the whole panel and give you all a bit of space to reflect and bring out comments that you would like to after listening to all the presentations. There's also a question in the chat around sort of urban versus rural, and maybe taking that even a step further just to think about the wide diversity of contexts and communities that we're working with. And then I think my question to you all would be if you can, just say a few words about what you would like to see in the space of community engagement in the coming years. So I just want to hand to each of you to, add points that you'd like to make and then address that question around what you'd like to see going forward. So maybe I can start with you, Kira. Would that be all right? And then we can go around.
Yeah, sure. Thank you so much, Mike. And I think thank you very much for the interesting discussions, and especially from the country learnings and all the comments actually in the chat and in the question. I think that's extremely important for us to learn, to listen to everyone in order to take those lessons learned into consideration in the future. I think when I was listening, I just had 4 quick points, and I think that's really important. The first one is we're talking about community engagement, participatory spaces. So it's really the capacities to invest in, especially on government actors. And here I'm talking not only about the high-level political commitment, but also the capacities on mid-level cadres who are actually then charged to do those participatory spaces within communities. So I think that there's a big need in order to increase those capacities, both governance sides and then of course community, civil society actors as well. I think what we also heard, and I think that was very clear from our two speakers from Ethiopia and Liberia, is that we need that whole of society approach within the future. So working across different sectors, across different actors, including civil society, community, civil society, is paramount in order to drive progress towards primary healthcare, UHC, SDG goals, etc. I think one option, when I looked a little bit into the questions and Q&A, and that reflects a little bit to what you had mentioned on rural versus urban. It also was one question about virtual versus in-person mechanisms. I think the key message here is really that whenever we have a policy question, that we are considering a mix of various participatory spaces, because there is not that blueprint out there where we can reach everyone. And the importance, especially anchored in the Leave No One Behind, is to really reflect who is participating, but also who is not participating, and making that additional effort to hear those voices who usually are heard less, who are not as powerful and have their direct context, in order to make their viewpoints clear. I think that's extremely important, considering vulnerable population groups, community, rural community. And here I think a mix of for example, virtual mechanisms, consultations, but also in person, going into communities in order to get their viewpoint is extremely important. And I think my last point is also what I would like to see in the future, is that we really move away from an ad hoc way of doing things. And we've seen it a lot in the COVID-19 response, where mechanisms were put up from one of the other day, but it's really to invest. And it's not about a huge amount of funding. It's more about that regular and sustained investment in those spaces in order to identify various actors, in order to build trust, so that then those participatory mechanisms, trustful relationship, can be used for health system strengthening within an emergency, but also, of course, within peacetime, in order to really engage and hear and consider those policies to be more responsive to the people's needs. Over to you, Michael.
Thank you, Kira. Rania, over to you.
Thank you, Mikey. I'll pick up maybe on Kira's point, just to be a bit provoking. And I would like to say that community engagement is costly, and investing in people and investing in community engagement outcomes requires better investments and resources. And I think that we need to shy away from that discourse and actually look at how do we engage more systematically with health systems, other social sector systems, to have a more structured and intentional approach around the resourcing that is required to achieve community engagement outcomes. And I'm stressing on saying community engagement, social behavior change outcomes, because oftentimes we use community engagement as instrumentalist. It's not the end, it's a means to the end. We want to promote community engagement for utilization of services. We want to promote community engagement for disease outbreaks, for whatever. It's always driven by what we want communities to do, rather than the actual outcomes of the building trust, of empowerment, of self-efficacy, of collective efficacy, of increasing confidence and decision-making processes at an individual as well as at a collective and community level. But just with the examples that Dube and Desalu presented, communities are taking decisions. Communities were setting up their own community surveillance mechanism, and over we find that. So if we want to be more prepared for humanitarian crisis or for outbreak response in the future, the divides between humanitarian action and development are superficial. Okay, they're driven by power dimensions, they're driven by how resources go and how donors invest in diseases that are very specific. But at the end of the day, these are communities and individuals, and we need to remove these superficial divides. What I would love to see in the future is having defining community engagement and social behavior change outcomes to be outcomes that we want to achieve. They are the pathway to achieve any change in terms of poverty reduction, etc., in the long term. But we need to talk about the operational and the institutional actions that need to be made. So this is when we talk about human resources within community engagement systems, we need to have better analysis on, do we have mid-level people that actually do plan for community engagement, that do the proper financial planning for community engagement, and then do we actually track expenditures and see that that's happening and see resources going into communities to invest in local capacities. So that's what I would like to leave everybody with. And thank you so much for this discussion. We couldn't go on for hours, I think. Over to my colleagues.
Thank you so much, Rania. That was lovely, and some important sort of, I think, calls to action and sort of continued concerted efforts for everyone. Over to you, Dr. Nyan.
Yes, thank you very much. I would really like to see more government involvement, and that will have to do with increase in the allocation of budgetary allotment for healthcare. These governments cannot, and it's not just the Liberian government, because I have experience with various other governments on the continent. It's not just, we can just be donor dependent. It still drives us into that aspect of not being self-sufficient. And there are enough resources, but if they only if they are appropriately allocated and the clear-cut defined policies are laid out for implementation, only then will we, achieve this. But what I see is that for Liberian government, for example, always wait on the donor, always wait on the donors. And for the most part, for this government, when the donors are coming in, they have their own picture, their own view as to what they want to implement, what they want to see as an outcome. But you, as the host country, you who are the affected country, should already have defined your own problems before the donor comes in. That way, in fact, you are able to redirect and shift the donor to what the donor was not even seeing as a priority. So only when these clear-cut needs are defined and the appropriate allocations are made, like I said, look at the slides that were shown. Look at the budget for the Ministry of States and Presidential Affairs, just a small ministry. And look at the budget for those two hospitals, just the two hospitals. It's a big and vast difference. So if they can put the money to where it really needs to be, you will in fact have no need for donors. You will have absolutely no need for donors. You will just need partnerships to get more qualified or technicians, more qualified or skilled professionals to come in and beef up what you already have. Now, talking about the rural versus urban, much of the activities are seen mostly in the urban areas, the big urban areas. Say Liberia, for example, say Monrovia, Ganta, those areas are accessible. But for the rural areas, for those who've been in our countries, you know that they are very, they are not accessible as much as you would think. When the rainy season comes, as it is now, it takes you weeks to go just 100 kilometer or 100 kilometer road. So they are cut off from these activities. What we've been able to do is then to use radios, for example, where one of the speakers talked about technology, whether visual or in person. Now, if we cannot go to in person, and due to rough internet connectivity, you cannot do visual also. So the radio also helps a lot in transmitting these communications. That was done during the Ebola crisis, and that was done during this time. And we spoke in the Pidgin English, the local broken English, and spoke in dialects in order to explain to the people what they needed to do in order to get themselves safe from the virus or from a particular epidemic. It was not just Ebola, it was not just COVID-19. In between there, we also had a measles outbreak. We had outbreaks of other infectious diseases. So that's what I think needs to be done. Governments define action so that we are not always dependent.
Thank you, Dr. Nyan, for that very clear message. And I see that you have a lot of sort of support from other panelists and the participants as well for really articulating, the position that governments can and need to be in, and also the ways that communities can really benefit from that and all of the experience that we have. So thank you so much. We're a little over time, so thanks to everyone who's able to hang in for a few more minutes. I want to pass to Desalu to have sort of the final word here on the panel. Over to you.
So thank you. Just two things. One is contextualization is very important. Context matters in community health system for every country. So understanding the context and designing context-tailored interventions and context-tailored community health system is very important. The second one is systematic institutionalization of community engagement strategies is very important. So linking the community health system with the formal health system and establishing the subsystems for the community health system is very critical, which includes the supply system, the financing, resource mobilization, and the information system, very important to institutionalize the community engagement and community health system with the formal system, with the formal health system. So having adequate and robust measurements and information system at community level is critical to institutionalize community health with the primary care system. Thank you. That's all.
Thank you, Desalu, and thank you all so much. I think this has been hopefully the beginning of more discussions. I think there's a lot of interest and a lot of, I really appreciate the chat and all of the questions and considerations and everything that participants have also brought up around the realities and the complexities and, you know, what's happening in their own work. So we're excited to share the slides soon. We're really happy and excited to hear from all of you. We hope you'll join upcoming webinar sessions as well, which will obviously be on different and exciting topics, and also really welcome your further questions, considerations, ideas on this important topic of community engagement for primary healthcare. So I think we'll leave it here for today. I wish you all a great rest of the day, and thank you again to everyone on the panel. Really, really appreciate all of your perspectives and experience. So talk to you soon, and goodbye for now.
Thank you very much, everyone. And
thanks, everyone. Bye-bye.
Wonderful moderation. Thank you, everyone, for your participation and interest. Thank you.
Okay. Bye-bye, everyone.
Bye-bye.